We have a relatively small number of implants per million and a relatively small number of centres. The majority of centres do implant both pacemakers, CRT and ICD devices, but around 100 are only doing permanent pacemakers. And of the 230 centres implanting, around 140 have a loop or more recently link implanting service. So there's about an average of 3 cardiologists per centre. Obviously there are some very small centres. We do not permit single operator services in the UK. This is because of standards introduced by British Heart Rhythm Society, and cardiologists are supported by expert physiologists and in some cases nurses. I think it's interesting to see that some years ago we moved towards remote ICD and CRT follow-up, and this was largely driven by problems with lead function in ICDs, so we could program on alerts to forewarn us when patients were at risk of inappropriate shocks. And so we've really managed with remote ICD and CRT follow-up for a number of years, but haven't adopted remote pacemaker follow-up except in the last couple of years. So I think there's about a 20% remote follow-up in the UK, and virtually all of that is ICD and CRT. I think COVID has had a massive impact across the UK, as we all know. All scheduled surgeries and face-to-face outpatient appointments were cancelled or postponed from mid-March until the end of May. In the UK, we saw an initial rise in the south, and then the conditions spread to the north. But now, as we see the second wave erupting, it's in reverse, more in the north than south at the present. But I think it's caused major problems. Much of our research, which was leading remote follow-up, had been suspended as research nurses and research assistants were moved into clinical care rather than research. We were fortunately reimbursed through emergency government legislation, whether we did face-to-face or remote follow-up for clinic appointments. And as Trudy said earlier, all our appointments moved to phone-based, which, although slightly more efficient, has created some problems in the nature of the diseases we're dealing with. In-house ICD follow-up has been suspended, so fortunately we can, in our centre and many other centres, monitor all our ICD and CRT patients remotely, but pacemaker patients are largely suspended and not being followed up at the present time. This is creating anxiety amongst our patient population, and I'm sure this is what drove the hundreds and thousands of calls that charities received and bodies like the Arrhythmia Alliance, with anxious patients wondering what was going to happen. So I think the important part of the message in the UK is that remote monitoring is reimbursed. There is a tariff for remote pacemaker or ICD follow-up, and it's actually the same as a remote outpatient consultation. And I think one of the big problems has been that we had a payment by results system that is currently suspended as we've gone to block contracts during COVID. Many trusts will receive the same remuneration next year as they've received this year. So by moving to remote follow-up, there won't be a potential loss of income, which has been in the past one of the major barriers for adoption of this new technology. Of course, remote monitoring is performed by physiologists in the UK, and they do require support from cardiologists and nurses, particularly when alteration in medication is required. I think what we don't do at the present time in the UK is follow up patients using third-party software and remote monitoring centres, except I think with loop recorders, where this sheer amount of information that's coming back and the number of times that patients press their alerts, this needs to be managed. And we'll talk in more detail in a few moments about how we intend to manage the huge amount of information that will be coming back to us from the patients as we move towards remote pacemaker follow-up as well as ICD and CRT. So in the UK, I think the real take-home message is that we're not going to lose out financially in hospitals, and that the drive, as we've seen, towards remote follow-up from patients and government is going to actually succeed in practice, although there will be some challenges which we'll talk about in a few minutes. have to state at the outset that I have a personal interest in this. As you can see, I have an 84-year-old father-in-law, my wife's father, who had a pacemaker 3 years ago after a syncopal episode. And when he was admitted to hospital, he had an MRI showing an old left cerebellar stroke, and he had some right-sided signs from this. He had sinus node disease and received a dual chamber pacemaker, and had been followed up with face-to-face follow-ups on an annual basis, and was doing very well. During the face-to-face follow-ups, they discovered some subclinical atrial fibrillation, less than 24 hours, and we'd recruited him into the Artesia trial comparing aspirin and apixaban. So he was under long-term follow-up, doing very well. But unfortunately, during the COVID period, he had a syncopal episode whilst driving. He was admitted to another hospital who interrogated his pacemaker and found some non-sustained VT. He's a very fit, active gentleman, in fact, prides himself on his physical prowess and his ability to walk up mountains every year in Germany. And he has a normal heart. So they put him on a beta blocker, reassured him and sent him home. But he was absolutely terrified. His world fell apart. He wasn't able to drive. He didn't feel confident to exercise. So I actually saw him as an outpatient in our centre at Liverpool Heart and Chest. He was terrified he'd had another stroke, so I did do an MRI to confirm no further change in his old stroke. But I then put him on to remote pacemaker follow-up, and I even did a download on him last night. And the beta blocker has stopped his non-sustained VT. It stopped his paroxysms of AF. He feels absolutely great. He's now starting to regain confidence to exercise and drive. I've got alerts programmed on so I can see if he goes into atrial fibrillation for more than 24 hours and then switch him to long-term anticoagulation. So the remote follow-up facility of a pacemaker has completely changed his life. It's also changed mine because he's not ringing me in an anxious state. And I think this just confirms the patient level benefit that remote follow-up has brought. We've seen this with our ICD patients for almost a decade now, that patients who've had a shock, who are then followed up remotely, knowing that alerts are on, knowing that we're at the end of a phone, at the end of email transmission of data, gives them huge reassurance. And I think this is going to be one of the major driving forces. And I don't think there's anything stronger than a patient-based story of the benefits for driving us forward in our quest to put everybody onto remote follow-up.